Good evening to one and all. It's my pleasure to welcome you all to the very first session of Critical Care Forum. I'm Dr. Haritha Rajakrishnan, and I'm a FCPI Critical Care Forum member. So, the role of clinical pharmacist in a few areas are already well known, including in infectious diseases, and I'm quite sure most of the attendees today have already completed or attended the infectious diseases forum, which has been released by the FCPI. But what other roles do we have, and what are the emerging arenas for the clinical pharmacists in India? So through Critical Care Forum, what we, the members of FCPI, we intend to do is educate you on the roles we as clinical pharmacists have. So critical care sector is one such area. And as the name itself suggests, critical care, we are basically dealing with the critically ill patients. So we are dealing with the patients who require intensive monitoring. They have, extensive medications. The fluid management is to be looked into, and a lot of other things. So it's like a combination of it all. So what role we as pharmacists have here? So it's not just about the medication alone. So before we start with the management, we need to know what the patient's condition is, what is the disease, what is the diagnosis, how did we reach into that diagnosis. So all this has to be, we need to have a basic idea on this. So, and considering all this, we have launched the Critical Care Forum, and where we will be discussing about various conditions and how we manage these patients, and many other things are in store. So, and today we have the very first presentation for the basic module in critical care medicine, and that is Introduction to Critical Care Clinical Pharmacy. And I'm happy to welcome the first speaker for the same, Dr. Abde Hussain. So he has completed his PharmD, and he has over 4 years of experience in dedicated to critical care, and also hands-on experience in ECMO dosing, therapeutic drug monitoring, and CRRT. And he has spearheaded the antimicrobial stewardship program for KIMS, Kingsway Hospital, Nagpur. He also has experience in pediatrics and neonatology specialty. So it's my immense pleasure to welcome you, Dr. Abde. So before starting with the presentation, I would like to mention few guidelines to the audience here. Abde, can we just move on to the next slide, please? Abde, am I audible, Dr.
Yeah.
Abde? Yeah, can you just move
Yeah.
on to the next slide? Yeah, thank you. So just a quick points to the audience. So the question and answer session will be taken at the end of the session after the presentation. So you can post your questions in the comment box and click the submit button. And by the end of the session, we'll be dealing with the Q&A. Next slide, please. And you can submit your feedback below the comment box itself. We have the option to submit your feedback, and that will be available after the session. So after submitting your feedback, within 14 days, you will receive the certificate of participation. Can we move on to the next slide? Yeah. So the certificates will be generated as per the data that is entered in your profile. So it will take almost 14 days to receive your certificate of attendance. Next slide. And the slides will be available for download by the end of session. So there's the icon for download where you can download the slides, but the login is mandatory to download the PowerPoint presentations. So with that, I think we can move on to the presentation. Over to you, Dr. Abde.
Thank you so much, Haritha, for your kind introduction also. And I think it is an immense pleasure and joy to kickstart the critical care forum of the FCPI with the first topic, Introduction to the Critical Care Clinical Pharmacy. So my disclosures, I do not have any financial. So starting with the learning objectives. So these are the points that we're going to cover in this presentation. So ICU, a room full of complex cases and catastrophe. There's so many things happening at the same time, and it is just a catastrophe waiting for happen. So what are the conditions that we commonly encounter in an ICU? The first one that comes into mind is shock. So shock caused by various etiologies, maybe cardiogenic, maybe obstructive, hypovolemic or hemorrhagic shock, or the septic shock. Now, septic shock, the second term that comes into mind is infections. Infections due to various etiologies, maybe pneumonia, the most common reason for sepsis in an ICU, necrotizing fasciitis, meningitis, endocarditis, neutropenic sepsis. So, a whole lot of varieties of infections. Then coming to acid-base disorders, that is probably a secondary complication due to these primary complications that occurs, followed by cardiac emergencies and arrhythmias, myocardial infarction, cardiomyopathy, tachyarrhythmias, bradyarrhythmias. Then coming to the neurological complications that we see in an ICU, strokes, seizures, traumatic brain injuries, SDH, SAH. There's so many issues after the surgeries that we have to perform in order to reduce the ICP. Respiratory issues, respiratory failure, the most common term that we hear in an ICU is the ARDS, the acute respiratory distress syndrome. COPD exacerbations, asthma exacerbations, and most obviously gynecological complications that occur, like HELP, eclampsia, trauma, poisoning, and burns, gastrointestinal complications like GI bleeds, hepatorenal syndrome, acute liver failures, and postoperative troubles, uh, probably surgical gastric surgeries, the complications that we face after that, and renal failure. Or probably a patient has missed his dialysis course and now has gotten admitted to an ICU. So prior to ICU, when we see a patient coming into emergency department, what, how do we make sure the patient, how do we evaluate that patient? So it is not easy as compared to other ward patients that we see, where we have enough time to evaluate these patients. But in case of ICU, everything needs to be rapid. The patient can rapidly deteriorate within minutes or hours. So in this case, a thorough history, well, at times you have to just be quick with the history, the physical exam, the blood images, diagnosis, and then come into the treatment plan. But prior to that, patient assessment always involves the ABCs. So what are the ABCs of ICU? First comes the airway, whether we make sure that the airway patency is present by asking the patient is able to speak. Are there any secretions in the respiratory tract that is hampering the airways? Then followed by breathing. Is the patient able to breathe? His respiratory rate, is it decreased or is it increased? Followed by circulation, whether adequate perfusion that we can check, uh, are there any compromise in the circulation? Now, once the ABCs are done, there is D and E, which is disability. How much, what is the consciousness of the patient? What is the delirium or any altered mental status that the patient is presenting with? Any exposure, so any toxins, so the toxins might be organophosphate, which might still be clinging to the patient's clothes. So all this evaluation is done. And another one is F, which is fever, so hypothermia and hyperthermia. So these are the quick analysis of an ICU patient that needs to be undertaken, and then followed by the history, the physical exam, further deep, like head to toe examination. Then we send the blood investigations, images, and then after the physical and the leads that we get from the imaging and diagnostics, we come to a therapeutic plan. Now, what will be the triggers if the patient is not in an emergency department? What if the patient is in ward and shows sign of deterioration? So how can we depict whether a patient requires an ICU stay or whether ICU admission or not? So these are the physiological parameters that comes into play, and there's a scoring called NEWS2, the National Early Warning Scores. So we can see the respiration rate, SpO2, air and oxygen, where the patient is breathing, the oxygenation is there. What is the blood pressure, pulse rate, consciousness, and temperature? And according to this scoring, if the score is 0, then most likely the patient will not require any ICU monitoring. If the score comes to 1 to 4, there is some requirement for monitoring, an intermediate level of monitoring. And if any score, if any parameter in that particular section has a score of 3, again, it will require close monitoring. But anything above that, a score to 5, will require an immediate evaluation by a specialized doctor, and with the score of 7 or more, an ICU team should be called in to monitor the patient and probably shift the patient to intensive care or a high dependency unit. So what are other prognosticators in ICU that we usually use, or the scores that we use? So the first one is the SOFA, the organ failure system, where we measure the oxygenation, where the patient is on mechanical ventilation, his platelets, his creatinine. So all these parameters are checked in, and we come to a conclusion how bad the patient is. So it has various pros and cons for it. So further investigation, further tests that we all other use are medical emergency triage and treatment systems, adaptive process triage, then the JUICE score, which further intensifies how much the oxygen requirement for the patient is. And all these things, like the SOFA, also uses GCS, the Glasgow Coma Scale. It is a very prevalently used ICU prognosticator for brain related issues. So coming to the ICU patients, they are always in a trouble, and we need to sustain the patient till the patient recovers. So what are these life-sustaining modalities, and what helps them to recover from this acute condition? So after doing the ABCs, we ensure that the patient has a venous access so that we can start the initial therapy, we can start the resuscitation towards the patient. So as we can see, a central venous axis is taken into the subclavian, an internal jugular vein, or a femoral vein. Its length is 15 to 30 centimeters. It can be multiple lumen, and more lumens the better, a triple lumen as compared to double lumen, as it helps in various drug administration. Now, what are the advantages of a central line versus a peripheral line? Since peripheral line is limited access, uh, it can lose its patency very early on and has a slow onset of action when administered for certain drugs like inotropes. It is very far away from the site of our action. With central venous access, we can put the drugs like inotropes directly, very closely, and very fast to the heart. So, and another thing that comes into mind through central venous access is that we require repeated sampling in ICUs. We need proper lab investigations, proper samples, and those are repeated punctures. Then administration of multiple medications. ICU patients are on so many medications at a single time. They might be inotropes, sedatives, hypnotics, neuromuscular blockers, antibiotics, and that peripheral vein access will not be sufficient enough. Second, the third importance is the hemodynamic monitoring and the extracorporeal therapies that might undertake later on. But there is a disadvantage, the risk of infection, the risk of thrombosis. Other vascular accesses that can be inserted are the PICC line, the peripherally inserted central catheter. Now it is longer than the central line, and it can be kept for longer duration as compared to a central line. A central line can be kept in place for at least 2 weeks, whereas the PICC line can be kept for at least 4 weeks to up to 6 months. The hemodialysis catheter. When a patient comes in for renal failure, a AKI on CKD, or a CKD patient who requires a dialysis in an ICU, the HD catheter, most likely a CKD patient will have an HD catheter, but all these cases where an AKI or new onset AKI is there in renal failure, a hemodialysis catheter is required, which will have an inlet and an outlet. Another major vascular access or the monitoring device in ICU is the arterial line. It helps to monitor the blood pressure, and it also helps in the arterial sampling. So ABG is an easy way because we need the arterial sample and not the venous sample for monitoring our blood gases. Then for further invasive monitoring of the hemodynamics in cases of shock, we require pulmonary artery catheter. It is very advanced stage where very few ICUs practice this practice. So pulmonary artery catheter, then followed by endotracheal intubation. Now we have all heard in an ICU the ventilator, the use of ventilator, and it is something to be feared, but it is a lifesaver, and it is the first step that comes into the ABCs. So in order to maintain the ABCs, the A and B, we need ventilator. So first, to ensure that the airway patency is there, if it is not, we need to go with the ahead with the intubation. So it is an anesthetic procedure which involves introduction of a flexible plastic tube into the windpipe, and to which a ventilator is connected, and this is referred to as invasive ventilation. At times, we might not jump directly to an invasive ventilation. There are other methods of ventilation where we first go into the nasal prongs, then use the bag mask, oxygen, then come into the non-invasive ventilation ventilator devices. And if the patient is not able to maintain on that, then we move ahead for the decision to intubate. Then what are the goals of mechanical ventilation? As the first goal is to reversal of apnea. That means apnea is a state in which the patient is not able to breathe. We must have all heard the term the obstructive sleep apnea, where we are not able to breathe in the moment of sleep. Then comes the reversal of respiratory distress. In various infections, surgeries, various other conditions, there is a stress that is created to the organs, and lungs are also not spared. So this causes a respiratory distress, increased rate of breathing, which we need to settle down. Then comes reversal of severe hypoxemia. This can be due to multiple reasons. The hypoxia, so infection is one of them, COPD, asthma, a long-standing COPD. So this leads to the decreased oxygenation into the blood. Then reversal of severe hypercapnia, when the patient is not able to exhale. So this leads to the CO2 accumulation. The CO2 accumulation is not good, and it further leads to metabolic complications, which we need to remove. Then prevent post-operative complications such as atelectasis. So in post-operative care and plus during the surgery, we have patients on various general anesthesia, sedatives, so the patient is not able to breathe. Now, what are the indications of ventilators? As we have already seen, like pneumonia, COPD exacerbation, we need to treat cardiogenic pulmonary edema. If not dialyzed early on, ARDS, aspiration of gastric contents, multiple trauma, chest traumas are one of the cases. So if there's a one-sided trauma where the lung is almost gone, so we tend to go for one lung ventilation. Immunocompromised host with pulmonary infiltrates. So again, the lung mass is gone. So it is not able to oxygenate. So whatever oxygenation that we can supply with the help of mechanical ventilation, then pulmonary embolism. Other indications in which we require general anesthesia, cardiothoracic procedures, and major non-cardiac surgeries. Shock due to all etiologies, patients at risk of aspiration, acute conditions such as neuromuscular weakness like Guillain-Barré myasthenia crisis, and apneic patients, which occurs in CNS damage and raised ICP. Another most common complication is the renal impairment. Now, what are the parameters that occur during the renal impairment? So accordingly, we go into the renal replacement therapies. First is the hyperkalemia. That is one of the most important indications for a renal replacement therapy, where the potassium level rises more than 6.5 mmol per liter and is a symptomatic where the ECG changes are observed. Severe acidemia. So acidosis again complicates the respiration as well and other organ systems. Uremic complications of renal failure, which can lead to pericarditis or encephalitis, and any toxin exposure that needs to be dialyzed, hypervolemia leading to pulmonary edema, and acute kidney injury. So acute kidney injury can be categorized, can be defined as a serum creat more than 0.3 mg per dl within 48 hours, serum creat rise more than 1.5 from the baseline in the past 7 days, and a decrease in urine output less than 0.5 ml per kg per hour. Now, etiologies of AKI. So first comes the pre-renal AKI. Altered hemodynamics, shock state can lead to a decreased renal blood flow and hence reduced GFR. So what happens when there's a reduced blood flow to the kidneys? Obviously, it requires oxygen and other nutrients to function. So because of the reduced blood flow, there's tissue damage. So this we term as a pre-renal AKI because of the changes in the hemodynamics. So what are the common pathologies? Hypertension, dehydration, drug induced like ACE inhibitors, loop diuretics, excessive diuresis. Then intrinsic category. So cellular damage to the renal anatomy, which occurs due to the nephrotoxin exposure, such as aminoglycosides, can lead to tubular ischemia and interstitial nephritis. Post-renal, such as obstructive cases, in which the urine is not able to pass and gets collected in the upper urinary system, which is common with pathologies are stones, benign prostatic hypertrophy, and urethral strictures. So what are the renal replacement therapies that we conduct in an ICU? First is the intermittent hemodialysis. This is undertaken when we need to remove fluids and know there is hemodynamic stability because the blood flows are very high. We cannot undertake a intermittent hemodialysis in a patient where hemodynamics are unstable, the blood pressures is dropping. So we need a stable because blood is removed at a faster rate from the body. Then there are certain prolonged intermittent renal replacement therapy, which are slightly different from CRRT. Again, the SLED, which is a kind of a mixture of hemodialysis and a CRRT. So the blood flow rates are a bit less as compared to dialysis, but a bit faster than the CRRT. Then comes the SCUF. So in SCUF, only the ultrafiltrate is removed, unlike other CRRT where we remove all the electrolytes and toxins. So what there are different types of CRRT, like the continuous veno-venous hemodialysis, which uses a different mechanism as compared to hemofiltration. So in hemofiltration, we have convection force, whereas in hemodialysis, we use the osmosis procedure. Then the combination of both CVVHD and CVVHF is the continuous veno-venous hemodiafiltration. So critically ill patients, how are they different from normal patients? So what are the factors causing PK changes in critically ill patients? As we all know that the drug's pharmacodynamics always depends on the drug's pharmacokinetics. If it is not able to absorb, there is no action. If it's not able to reach the target site, there is no action. So what are the factors? So first one is multiple medications. Then comes the coexisting comorbidities like drug disease, drug-food interactions, changes in the protein binding because of the drug disease. Probably unfed state leads to the protein decrease in the body. Again, the changes in the protein binding, adverse drug events, pathophysiologic changes like hemodynamics, metabolics, and biochemical derangements. A lot of fluids that we give in ICU. So that again changes the volume distribution, obese versus a lean patient. There's changes in the pharmacokinetics in both the patient populations. Then the use of organ supports like mechanical ventilation, RRT, ECMO, where there's a chance of an increase in clearance of drugs. So a good table to remember is the pharmacokinetic changes in the basis of the absorption, distribution, metabolism, clearance, and certain related to antibiotics specifically. So first one is the pH changes in absorption. So again, the gut pH change that occurs because of the use of pantoprazole that we use for stress ulcer prophylaxis. Again, certain acid drugs or the base drugs can get altered absorption. The perfusion to various tissue sites is impaired because of the use of inotropes or vasopressors or in shock state. So the absorption of drugs such as enoxaparin or any orally administered drugs can get altered. The GI transit times and transporters are changed because suppose a patient with diarrhea again will have an increased GI transit time and will not be able to have a proper absorption through the oral route. Then there comes the factor of enteral feeding. A lot of drugs can get decreased absorption because of the presence of enteral feeding like phenytoin. Then comes the VD changes. So what are the factors? Hypovolemia, hypoperfusion, all those fluid changes that occurs can lead to the change in the volume distribution. The volume resuscitation that we use 1 liter, 2 liter of IV fluids again will change the statistics over there. Fluid shifts and third spacing because of shock state, binding of protein decreased by protein content in the critically ill patients. Metabolism changes like hepatic blood flow can either increase or decrease. Enzyme induction and inhibition can change because of certain drugs. Again, those are inducers or inhibitors. They can alter the other drugs' metabolism. clearance such as end organ dysfunction, acute renal conditions, and RRRTs. Critical illness and organ systems. When we think about critical illness and defining each organ systems individually, if we take them, what are the changes that occurs in them? So drugs that have high hepatic extraction ratio, such as fentanyl and propofol, again with reduced hepatic flow in shock states, these drugs might not have adequate elimination. So these drugs start to get accumulate and can show signs of toxicity. Decreased hepatic metabolism, protein expression, and CYP enzymatic alterations. So a lot of CYP substrates that we use in ICUs like haloperidol, propofol, voriconazole, fentanyl, clarithromycin, all these drugs are commonly used in ICU and they are CYP substrates and at risk when used with CYP inducers or CYP inhibitors. There might be changes in hepatobiliary clearance as well that needs to be taken into account. The GI tract changes, as we had already seen, the pH alterations. Now, again, the drug can have a decreased absorption in cases where there is GI bleed. So that again is a factor that affects. There's a mucosal disruption and various etiologies such as shock, respiratory failure, obviously drugs, anticoagulants, antiplatelet, NSAIDs, and other stressor factors can lead to risk of upper GI bleed in an ICU. That is why we use pantoprazole to protect and have a stress ulcer prophylaxis. Then renal changes. There's an inverse relationship between the BUN and CYP3A4. So an increase in BUN will lead to a decreased function of CYP3A4 and further decreased metabolism of drugs which are cleared by CYP3A4. Reduced clearance and increased VD. So due to the decreased clearance of the water and fluid accumulation can lead to an increased VD and independently then affects the half-life of various drugs such as benzodiazepines and opioids. There can be accumulation of metabolites such as morphine. Then limitations due to accumulation of formulation excipients such as voriconazole injection containing the cyclodextrin. Then creatinine clearance often correlates linearly with elimination with hydrophilic drugs, but obviously there are certain lipophilic drugs also which are renally cleared. CNS changes that we see are the blood-brain barrier disturbance, which can occur initially and lead to the toxicity, drug toxicities. In meningitis cases, I think so that is an added advantage, but for certain cases, it can lead to increased neurotoxicities. So what are the CNS conditions that we see or the changes that we see are the raised ICP, hypoxic or ischemic insults, Parkinson's, Alzheimer's, epilepsy. Again, we have to see in these patients which drugs they are on. So again, the drug-drug interaction interplay will take place. Traumatic brain injury, CNS infection, brain tumors, and we have certain drug adverse effects that we need to monitor, like excessive sedation with opioids and benzodiazepines, benzodiazepine-induced delirium, withdrawals because of alcohol and nicotine, seizures by various antibiotics, neuropsychiatric adverse effects with antibiotics. Then there's a change in immune system. What so first is the systemic inflammatory response, where there is an over stimulation of the immune system in cases such as sepsis, major surgery, trauma, CNS injury, burn in, which leads to a loss of skin, a primary defense system, pancreatitis. After the 1 week, the SIRS comes in, organ transplant, again, patients on medications, immunosuppressants, cardiopulmonary resuscitation, hepatic and renal dysfunction. All these factors have somewhat contribution towards the inflammatory response that occurs in the body. What this leads to. So, So defects in the immune system, the adaptive immune system, decreased phagocytosis. Defects in both innate and adaptive immune system, reduced antigen presentation, and decreased phagocytosis. So intensive care unit acquired weakness. Now, after all the organ systems have been affected, there is a chance where the patient will have these stressors affecting the outcomes. So there's an acquired weakness that occurs. So the risk factors can be non-modifiable, such as the severity of illness. So worse the severity, the weakness is more in those patients. Demographics such as female patients, old age patients, patients with a lot of comorbidities like diabetes, hypertension. So these are vulnerable patients to acquired weakness. Then modifiable certain things that we can control, such as hyperglycemia. And hyperglycemia if has an importance in this, and we can control it through insulin infusions, parenteral nutrition, immobility because of the mechanical ventilation or various other reasons. Drugs can lead to the weakness, such as steroids, neuromuscular blockers, vasoactive medications, certain antibiotics like colistin, and sedatives. So this will have the short-term complications and long-term complications. We are not able to wean the patient from mechanical ventilation because of this weakness. The ICU hospital length of stay is more, the hospital mortality is more because length of stay is more, mechanical ventilation leads to, again, risk of infections. Swelling disorders are there, and all things accumulate into the increased ICU cost. Long-term complications, post-ICU mortality, patients not able to survive after ICU, they can get to discharge home or to a rehabilitation center. There is a reduced physical functioning in these patients. So post-intensive care syndrome. What do we see after the patient gets discharged from ICU? These are long-term cognitive impairments such as cognitive decline, risk of dementia, impairment in daily activities, long-lasting pulmonary dysfunction. So once the damage is done, these damages needs time to repair. It can take as long as 1 year with radiological clearance, again taking time. Immunosuppression, we saw all those factors affecting the immune system, and it might take time for them to recover back. And again, they are at risk for further infections. Then long-term kidney injuries. So once the AKI sets in, there might be a chance that it can recover or it can progress to a CKD or an end-stage renal disease. So further complications of drugs, we need to make sure that these drugs are monitored. Sustained muscle weakness, we saw the steroids, neuromuscular blockers, all these affect the muscle strength, the muscle mass is lost, the contractility and endurance is lost. So again, to regain the physical activities after ICU stay is delayed and again affecting into the post-intensive care syndrome. So now the know-how of the ICU medications that are used. So first are the inotropes and vasopressors. So we can see all how they are affecting the hemodynamic parameters. That is very one important thing to know about various inotropes that we use in an ICU. It can change according to the condition and the type of hemodynamics that we are targets that we are set. So dopamine, again norepinephrine, the first choice of drug for any shock. Epinephrine, after norepinephrine and vasopressin, the epinephrine is a choice of drug in septic shock. Dobutamine, again with the risk of arrhythmias and vasodilation. Milrinone, levosimendan, a bit of a rarity nowadays. It's not available in India. Terlipressin, mostly used now in hepatorenal syndrome. And angiotensin 2, the studies are still ongoing. With the use of inotropes and vasopressors in shock states where we need to maintain the BP, there comes a price that they are the adverse effects. So tachycardia, cardiac arrhythmias, very less with norepinephrine, but peripheral ischemia with longer use and higher doses, yes, it can set in. Epinephrine, again cardiac arrhythmias, peripheral ischemia, the risk of lactic acidosis, hyper or hypoglycemia, and splanchnic vasoconstriction. Dopamine and dobutamine have a bit of limitation and mostly nowadays used in certain cardiac conditions. Phenylephrine, where a drug to be cautiously used. Vasopressin, again, a very good drug after norepinephrine for septic shock. So the vicious cycle, then coming to the next part is the vicious cycle, the delirium, pain, and agitation. So we see all those medications, all those complications. We have mechanical ventilator, we have the venous access, so many procedures that are undertaken on these patients, and they're bound to cause pain to this patient. Now, this pain is unbearable and can further set in delirium or agitation. Plus, there are other factors that can further worsen the delirium or aggravate the agitation that occurs. And this leads to further complications such as uh, we have a longer time for weaning from the ventilator, increased ICU length of stay. So we use a we use a method called anglo sedation. where we balance both the sedatives and analgesics when required. So the first choice that initially was used was midazolam, but because of the delirium, now we have switched to the opioids like fentanyl, most commonly used in ICUs, but it has its own side effects such as nausea, constipation, respiratory depression, opioid withdrawal. Dexmedetomidine, another safe drug that can be used, but it comes with a risk of hypertension. So avoid loading doses with dexmedetomidine, and a continuous infusion is used. Propofol with prolonged infusions can lead to propofol-related infusion syndrome, and acetaminophen for analgesia. So your case, a 65-year-old male with a history of coronary artery disease, hypertension, CKD, stage 3 severe aortic valve stenosis is underway, respiratory laparotomy for suspected intestinal obstruction under general anesthesia. The surgeon is requesting paralysis for the duration of the surgery. Now, which of the paralytics should be avoided in this patient, giving the patient's comorbidities? So, coming to the neuromuscular blockers. As we see, there are two types of depolarizing and non-depolarizing neuromuscular blockers. Succinylcholine with the risk of hypokalemia, malignant hypothermia, atracurium very well tolerated and metabolized not by renal and hepatic. Cisatracurium again well tolerated. Vecuronium with vagal blockade with large doses and bradycardia. Rocuronium again well tolerated, and pancuronium with tachycardia, hypertension, and flushing. So if we go back to the case, can you point out any of those things that might lead to the complication in this patient? So yes, pancuronium, because of the tachycardia and hypertension, which might further complicate the case, should be avoided in this case. Now, while using neuromuscular blockers, we have other considerations that we need to take into consideration, such as neuromuscular weakness, eschar formation, keratitis, corneal abrasions, and increased risk of venous thromboembolism. Antiarrhythmic drugs. So vastly use antiarrhythmic drugs because of all these complications then subsequently can lead to cardiac abnormalities and precipitate arrhythmias. So adenosine for supraventricular tachycardia, a rapid IV bolus push, not to be given slowly for treatment. Esmolol, metoprolol, again beta blockers that come into play for IV drug. Diltiazem, calcium channel blocker that we use for tachyarrhythmias, digoxin, and amiodarone. Amiodarone is the most widely used antiarrhythmic drug, the most wide spectrum antiarrhythmic drug, and is used left, right, and center in an ICU setup. Moving on to insulin in ICU. The risk for hyperglycemia are there because of the stress that is created. The shock state probably lead to the insulin deficiency or the insulin inactiveness to the various sites. Now for this, we cannot give oral hypoglycemic agents in this state because of all the hemodynamic instabilities, the altered absorption. Metformin again cannot be given in renal failure. So this leads to a choice of drug insulin. So what are the target blood glucose levels? It is to be maintained between 140 and 180 mg per dl. So any trigger above that can you can start on the insulin infusion. Now we have multiple choices for insulin, as we can see how the graph shows how much of the action, duration of action. So initial in the hemodynamic instability phase and where the blood glucose are fluctuating, we need a shorter acting insulin. So we most commonly use the regular insulin as an IV infusion. Again, the subcutaneous route is not used initially because of the perfusion issues, and IV access is there. So IV fluids, another main drug in the ICU. Yes, it is considered a drug again. So what are the different, the crystalloids, the colloids, and the blood products? These are the different IV fluids that we use. And we used it for 4 different purposes. First is the resuscitation. Patients with shock have a volume deficit and which needs to be corrected with fluid boluses of 4 ml per kg and given fast over 5 to 15 minutes. Then comes the maintenance fluids, where we use the basal requirement fluids of 35 to 30 ml per kg per day and also provide nutrition and electrolytes in the form of glucose. So 1.4 to 1.6 grams per kg per day, And the main electrolytes that we need to replenish are the sodium and potassium. Then we need to consider what are the replacement fluids. Why do we need it? Because of the fever, drains, stomas, diarrhea, open wounds, polyuria, surgical loss. There's a lot of fluid loss that is occurring. So we need to correct, we need to calculate, we need to observe how much of fluid loss is occurring and add to the maintenance fluids. Then comes the nutrition fluids to cover the daily caloric needs. So feeding and nutrition ICU. Now, obviously, the patient is not able to eat, the patient is sedated, paralyzed. How we are going to solve this? So, what are the goals for nutrition? Is to preserve the lean body mass. Obviously, the body needs the energy to fight the infection, to fight on this acute condition that is undertaken, maintain the immune function, avoid metabolic complications, prevent malnutrition that can take place. And those are the signs like cachexia, edema, and muscle loss. So it is tailored as per patient's daily requirement, which is a calorie requirement of 25 to 30 kilocalories per day, and a protein requirement of 1.2 to 2 gram per kg per day. Now, there are two methods where we can provide this nutrition. First is the enteral nutrition, where we put in the rice tube and start within 24 to 48 hours of the ICU admission, most likely in a stable patients. In patients where we cannot provide enteral nutrition, where there is probably a surgical case or some complications, we need to switch to another method, that is parenteral nutrition. Since already we have a central access, we can start the patient on total parenteral nutrition. So then infection control practices. So in every ICU that is, we see there are patients at risk for infection. There are so many procedures, so many complications, they are vulnerable, and we need to ensure that we do not do any harm to these patients by providing a chance for infection to come in. So what are the steps that we can take to prevent these patients from getting infected or getting hospital-acquired infections? So first is the hand wash, which is a very most important step on preventing transmission of HAIs. There's a 5 moments of hand hygiene that needs to be undertaken while taking care of the patient. And it can be taken with help of soap and water and alcohol-based hand rubs. Now, during the surgical procedures, or we saw in the state of COVID, where we needed to use the personal protective equipment, where at times it can provide protection to both the patient as well as to the care provider. So now coming into the hospital-acquired infections, how we can see this. A PICC line was in place for a patient on June 1st. The patient became febrile on June 3rd. The PICC line was still in place and cultures were taken which came positive for Staph aureus. So can we take it as a hospital-acquired infection or a CLABSI? Second case, PICC line was placed for a patient on June 2nd and removed on June 5th. The patient became febrile on June 6th, and the cultures grew positive for coagulase negative staphylococci. Is this the case for central line, again, a line inserted bloodstream infection? So which of the cases? Either case 1, case 2, cases 1 and 2, or none of the above? So let's see. So what are the ICU acquired infections that are there? First is the ventilator associated events, and a more terminology that we commonly use is the VAP, the ventilator associated pneumonia. So it is a deterioration in respiratory status after a period of stability or improvement on the ventilator with the evidence of infection or inflammation that can be probably radiological or a lab investigation that shows us, and laboratory evidence of respiratory infection and mechanically ventilated for at least 4 days. This is for VAE, but the earlier definition for VAP was only a duration of 48 hours for the infection to set in after a patient is on a mechanical ventilator. Then comes the central line associated bloodstream infection, CLABSI. So we can see which are the sites or sources of infections that can occur because of the insertion of central line and how it is to be why the central line insertion is a careful process. So it is a laboratory confirmed infection where a CVC is in place for more than 2 calendar days prior to a positive culture and is also in place the day or a day prior to culture. So these all two are both checked the boxes for the case 1 and 2. Another infection that ICU we need to monitor is a COTI, a UTI where an indwelling catheter was placed for more than 2 consecutive days. The catheter is placed for 2 consecutive days and then removed. For UTI to be considered COTI, the event should occur on the day of removal or until the next day. Then UTI signs that we observe for COTI: fever, suprapubic tenderness, costovertebral angle pain or tenderness, urinary urgency, or a frequency dysuria. So looking at these things, now we have known what the ICU patient looks like, what are the ICU medications that we use, what are the life-sustaining modalities that we use. Now, where do we come in? What are our roles and responsibilities as a clinical pharmacist in an ICU? Well, it looks very complicated, but there's so many tasks, it could be overwhelming, but we can start from one-to-one process. So I think so the primary objective should be the medication management, where we participate with the daily rounds, look into the drug order review and provide modifications or suggestions. We can identify the drug therapy related problems, undertake medication reconciliation, and again optimize the medication plan. Then patient assessment is a very important step. Now, along with the rounds, we have to take into our individual patient assessment that will help us in tailoring or providing a suggestion for the therapy. Then providing drug information that can include PKPD, TDM, other therapeutic options that are there, adverse effects and monitoring, clinical consultations, not only the ICU but outside the ICU. And once the patient has moved out of the ICU, we can provide our clinical consultations. We can provide drug therapy monographs and formulary reviews through the PTC, the Pharmaco and Therapeutic Committee. In there, we can play a crucial role. Then we can undertake various quality improvement projects such as medication safety, adverse drug events reporting, and making sure we have a good quality of medications coming in. We can report on various quality metrics that are there. We can help in the ICU accreditation that specifically enhances the ICU performance, education to critical care members, patients and patients' caregivers, and other health professionals, and collaborating with the ACLS and other emergency teams. We can take into the neuro emergency, cardiac emergencies. We can provide medication related consult even to other specialties, other clinical pharmacies. We can collaborate with them, and also the dietitians for the nutrition therapy. Then there are certain administrative tasks that we can undertake, such as the stewardship activities, documentation of all our interventions and activities that we undertake in an ICU, the pharmacoeconomic analysis, and how the money part plays an important role, as we always need to provide a way, show them that how we are reducing the cost in an ICU. We can undertake new clinical pharmacy programs and processes for disaster or mass casualties. So what are the certain low-hanging fruits that all of us can practice in an ICU? So first comes in the medication reconciliation. An example of that would be to continue the long-term psychotropic medications, or as simple as an eye drop for glaucoma. And so this requires a proper medication history prior to that, and then only we can do a medication reconciliation. Then adjusting the dose and frequency of medication administration, like reduction of gabapentin and pregabalin dosing in kidney failures, reviewing the continuing need for medication patients if clinical status is altered, such as discontinuation of prokinetics after ELIAS is resolved, acetazolamide again after, assuring appropriateness of formulations, hepatic monitoring with APTT, LMWH monitoring with NT10A factors, detecting and avoiding drug interactions, avoiding combination of valproic acid with meropenem. I know there are multiple drug-drug interactions that we can see every day, but it is very important to analyze, is that drug interaction really affecting a patient, or is it significant for that patient? Pre-scheduling the administration times. There can be, at times, drug which needs to be administered in the morning but giving in the night. Those all things can also occur. And also reducing the overnight medication administration. Again, some patient might be, not that critical, but yes, needs ICU monitoring and, needs to sleep at night. But because of the doses that come into the night, the patient is not able to sleep. Again, that can affect how the patient gets better over time. Then proposing changes to the pharmacotherapy in accordance with evidence. We should always look for the new evidences and the best guidelines that are coming into place. And again, there's always a debate, what kind of antibiotics, how to give them, what are the TDM parameters, which is the best way to monitor them. Then switching dosing route. an easy intervention that can be made in ICU when we know the patient now is able to tolerate or take oral food and everything. So switching all the IV medications to oral medications as soon as possible. Again, it will save cost and also reduce the risk of infections. Then therapeutic drug monitoring, again, providing the chance or the information of when to TDM, which patients or subsets of critically ill patients that need to be undergo TDM. All these complications, all these so many things where we need a checklist. This is the fast hug BID where we, have doing arounds, we can just tick everything like, okay, feeding undertaken correctly, analgesia is going on, sedation, yes or no, is it still required? If no, we can discontinue. If there's a risk for thromboembolism, so is the patient on thromboprophylaxis or not? Head of bed elevation is there. Also prophylaxis, whether the pantoprazole or whatever other means for prophylaxis ulcer is going on or not, whether the sugars are in control, what is the current status, whether are we giving insulin IV, are we switching into subcutaneous, or now can we go for OHAs, spontaneous bleeding trial that is more for the mechanical ventilated patients, bowel regimen, whether patient has passed his motions or not, that again we can correlate whether is there any GI motility or not, indwelling catheters, another risk for infection, and de-escalation of antibiotics. And another another useful checklist that we can use is maintenance, where we can reconciliation, antimicrobials, what are the indications for medications, the drug dosing, electrolytes, hematology, labs, whether any drug interactions, allergies or duplications or adverse effects, or any stop dates that we need to check in. A very useful a step-by-step approach in learning into the ICU. I know it is very complicated, and students and everybody coming in saying, okay, how we can learn such a complicated scenarios. So first starting with individual drug, where we know what is the active ingredient, what is the mode of action, and what are its therapeutic effects, the basic pharmacology. Then we go into the treatment level, where we come into various disease states. What are the first choice of drugs? How to administer it? What are the doses of that? Then coming into further step of significance, where we can check in the interactions, not only just the drug-drug interaction, but the drug-disease interactions. What are the different administration routes that we can uh, give the patient in case that access is denied in certain patients, where we cannot give oral formulation. So can we come up with a different formulation? And IV access is not there. So can we again switch to another route of administration? The knowledge of high-risk medications such as concentrated electrolytes, we have neuromuscular blockers, so many drugs that are high risk and can lead to various harms to the patient. Then obviously, very important step is the interpretation of the laboratory values. If you're not able to understand the labs, how are we going to monitor the medication treatment plan that we have devised for the patient? And how do we will monitor further if any changes are required or not? Then comes the medication review competence level, where the management of the whole medication regimen we can undertake singularly in a whole case scenario. So this is the ICU team. So it is not just the pharmacist, it is a collaboration of all the participants, the intensivists, the microbiologists, dietitians, physiotherapists, nurses, psychologists, and palliative care. So we have to work together in creating a drug therapy plan that helps and in a better recovery for the patient. So I suggest further readings for ICU. I think so ICU book, the Paul Marino, Washington Manual. So all these guidelines, this will help in the practice of practicing in ICU. So take home messages. So ICU care includes treatment of underlying disease and organ support, fluid and electrolyte management, nutrition and prevention of complications. We also aim for do no harm. The goal of analgesia and sedation is to make ICU stay bearable and to avoid negative physiological and psychosocial consequences. Pain must be dealt first. Then extreme pathophysiologic changes are common in critical patients. We need conventional dosing regimens may not be appropriate for critical patients due to the altered physiology and illness severity. One must possess an in-depth knowledge of PKPD, essential to the ICU pharmacist to comprehend the complex effect of pathophysiologic changes. The daily assessment of ICU patient is must and should be done in a concise and a structured way. It consists of carefully checking patient notes, gathering information from nurses and allied healthcare professionals. A critical care pharmacist plays a crucial role in medication management, preventing ADE, and demonstrates improvements in clinical and economic outcomes. So do not miss the further events that are going to happen in the coming days. First is the top papers in tropical infectious disease by Dr. Venkat Ramesh on 23rd of March. Then we have the understanding of the intravenous and antimicrobial dilutions and drug compatibilities the following next day on 24th of March by Haritha. Then we have another basic, the second presentation of the basic module in critical care medicine, an introduction to shock by Dr. Shubham Kandhare on 29th of March. Thank you. Any questions?
Thank you, Dr. Abde. That was a wonderful presentation. I should say, like, you presented the whole topic in a very simple way and was like, I just attended a crash course on critical care pharmacy. Wonderful presentation. Thank you so much for that. So before I move on to the questions, I think it will be only justice for the attendees here if I would like to ask you to share your experience as a critical care pharmacist, because I mean, like, a lot of queries will be there in the student's mind also. I mean, like, what are we, I mean, I know you have presented it very well, but still, because I don't think all the students get to attend the ICU rounds on a daily basis, because most of the time they're like restricted to the wards and, just doing the regular jobs, because ICU, I mean, we have few restrictions on the entry as well. So I'm quite sure they're interested to know what you do on a daily basis and what are the challenges, if you could share with us 2-3 challenges you have faced during your postings, or maybe your role when you were a clinical pharmacist in a critical care. So yeah, over to you.
Yeah, I think so. The vastness of it, uh, it's so many things that we have to study in a single time, and to know all of those things can be very overburdening at times. But I think so. The thing is to take it step by step. We cannot achieve everything in one day, so we can try to prepare it one organ system after the another, one drug at a time, and then combining those things. So that helps a lot. I always tell my students to, go see the drug chart. What are the drugs? First, get familiarized with them. What are the, common dosages that we see in an ICU? So, in that, then the second thing was coming up with, deciding the whether which treatment is right. I think so. We have very complicated cases, and it is a very uncertain. We don't have evidences at times for a lot of therapies, whether we should go for this dose or that dose. With the renal dysfunction, hepatic dysfunction, this drug again has both of them. So which drug to choose, and you know, not to complicate the patient any further. So that is one of the challenges, and still is.
Okay, great. So, what is it that you do on a daily basis? Like, how does your day start, and what are the things that you look into when you see a drug chart, or how do you manage your patients? And what are the patients you actually have to see on a daily basis? Can you just brief about it?
Yeah. So my day starts first with the handover. So we have a system where the night doctor gives handover to the morning doctor. So that again I attend. And there's after that, taking in all the information, what has happened overnight to the patient, and think in my mind, okay, now, which drugs I need to think of. So, just preparing myself for the further rounds. Then if I get the time, I'll take my individual rounds, those questions that I had in my mind during the handover. Again, I check those and see, with the help of the FastTag BID and everything. So, drug interactions and everything. And obviously most focused to, with the patients on mechanical ventilator or CRRT and all those modalities. And obviously ECMO will be the first preference to my checking if there is a patient. So all these patients we need to prioritize, the more the bad the patient, and salvageable, we need to look into them first, and then probably move on to a more stable patient later on. Then comes the daily rounds that we have with the intensivists. The nursing team is there, the physiotherapy team is there, the dietitians are there. So we all look into, I have my laboratory investigation, the lab investigation that have been ordered. So we have results on our mobile. So always keeping that on, and have my tabs ready. As soon as the doctor asks, okay, can we give this or can we give this dose? Is it okay or not? Checking all the pharmacokinetics of the drug at the same time. So in that rounds, it helps a lot. What are the again new findings that come into place, and what are the new evidences that we have collected, and matching with that with the laboratory investigations that have undertaken. So yeah, basically that.
Yeah, I think that's a very the last point you mentioned is totally right, because about the when it comes to dosing, the physicians, they just right, they just turn to us and they're like, okay, what's the dose here? So okay, go adjust the dose. I mean, that's the one thing that they are like very much they require our guidance in, because especially when it comes to the patients with renal impairment or even hepatic impairment, that's the first thing that comes in. They're like, okay, fine, this requires renal adjustment, or whether this drug can be given or not. So that's one thing. That's a top role that we have to play in a critical care setting, I feel, because most of the patients, most of the time they have this renal impairment issues. Yeah, so that's like a right point that you pointed out there. So I think we can move on to the few questions from we have received from the audience. So you had mentioned a case where a patient we had inserted a PICC line and then he had an infection, and then you just mentioned a few questions on that. So it's not related, entirely related to it, but so basically, if a patient is has PICC line and is a patient is receiving TPN through PICC line, so is it mandatory that we need to stop TPN at that time, or can we continue total parenteral nutrition when through the same PICC line, or is there any requirement on stopping the parenteral nutrition via the infected PICC line?
I think so. If the PICC line is infected, I think so. The first step will be to remove the infected PICC line. So
No.
probably we'll have to hold the total parenteral nutrition during that period, and till another PICC line is inserted, and we still start the antibiotics. And again, TPN is another risk factor for infection,
Hmm.
which again is a source of infection because of the nutrients. So again, very carefully monitoring with the next line that we put into first. I think so. We'll be treating the infection if it is an infected PICC line, definitely. Yeah,
Okay, so the first
that
step
would
would
be
be to remove the
process.
PICC line, then to treat the infection, and then once the infection is
Yes,
controlled, we'll be moving ahead with the nutrition, isn't it?
nutrition. Yes.
Okay, good. Okay, so in a critical care, in an ICU setting, when as CPs, when we look into a drug chart, where should we primarily focus on? Where should the focus be? I mean, is it what is it to be looked into? Is it the antibiotics, or is it the analgesics, or what should what where should our focus be? That's another question.
Yeah. So I think so. Mostly it is antibiotics, majorly antibiotics. Yeah, but still I think so. There when you have multiple medications, and again, what kind of patient is there, it changes accordingly. So antiarrhythmics again, whether dilution is being there correctly done or not. But most of the focus, yes, it is related to antibiotics. Then again, with the fast hug, the checklist that we have, whether pantoprazole is present or not, whether enoxaparin, whether the dose of enoxaparin is adequate
Mm,
according to the weight and everything. So the focus should not be just on antibiotics. I think so. A CP can get you know waived in that way only, looking every time into the antibiotics, but it's a lot more. So like the prokinetic drugs, their adverse effects, a lot of people forget to check whether what interplay that has. So whether the timings are being adjusted, the
mm.
compatibilities. So there are a lot of other things that needs to be taken into consideration apart from the antibiotics.
Okay. So, what is the most challenging thing you have faced? Because as you have mentioned, there are like a lot of things that impair, like in a critically ill patient, they have a lot of things going on. Because first of all, it's like polypharmacy. I mean, you have like thousands of medications that patient is receiving, and then there's a choice of fluids. Like we need to look into whether the patient is actually, if it's hypertension, or if the patient is diabetic. I mean, the choice of fluids changes totally there. So, what are the challenges actually you frequently face? I mean, what is the most frequently faced challenge as a CP?
I think so. One of the cases, like I would like to just elaborate, is one we had a case of HELP, and later the patient developed butt chiari. So again, a pregnant patient having gynecological complication, and then developing Budd-Chiari. So in that case, it was very difficult to give the anticoagulant choice. Again, because the renal impairment set in and coagulopathy, and so we needed to give anticoagulants. So what choice to give? So like these kind of complicated cases. Uh, we have faced. So I think so coagulation choice, when both renal and liver dysfunction, and when the drug excretion is dependent on both of them somewhat. So those are the cases, and where we have lack of evidence for certain cases, like when to start the steroids. I think so with the recent guidelines, I think so yes, but again steroids with the complication that it comes with. So
Yeah.
there's so many doses of steroids that again to choose the right one, but seeing
Yeah.
very wrong doses at times and causing a lot of complications.
Mm. Even the conversion is also hard to do. I mean, because
Yes.
hydrocodix, vice learn. So
Yes.
you need to know the right conversion, and you need to tell them also. I mean, most of the times we face a lot of errors because of the same. Okay, great. So in an ICU setting, so how do you do the medication reconciliation? Because all the time we tell our interns and students that, okay, so your role is to do medical reconciliation. That's an important step because once the patient gets admitted, you need to make sure that the old medications are reconciled and it is looked into. And we need to make sure the medications are ongoing because hypertensive medications or diabetic or whatever that may be, anti-epileptic medications. So how do you make sure in the ICU setting that you have properly reconciled the patient's medications? How do you do that?
Yes. So I had formulated one medication reconciliation form in the hospital. And plus, when I used to go on my individual rounds, and we had a policy where the patients used to, relatives used to come in. So if the patient is able to talk, I used to talk with converse with the patient itself and ask them whether they were, I could see from their comorbidities, diabetes, hypertension is already mentioned. So they must be on something,
Mm-hmm.
and even if it is not mentioned, I'll still have a word with the patient whether they had any recent exposure to any drugs that they took, NSAIDs or antibiotics that they took. And during the visiting hours of the patient's relatives, I used to have a conversation with them, and if they are not there, I would used to ask if they are available to talk, and ask them what are the medications, and if they have, can they bring it so that I can check. And once it is checked, I would used to put those medications in the list. Otherwise, mostly it used to happen when in the initial admission time itself, but if it is missed, I would make sure that I take part in it.
Great. So has there been any situation where, like the reconciliation was missed and the patient's old medication was not reconciled into, and because of that particular thing, the patient had to undergo any severe crisis or anything? Has there been any situation like that, whether which you encountered?
Sorry, I cannot recollect as of now in case such
No, I just
in
recently
such
I had
cases.
to
Yeah,
encounter one similar situation, so that's why I was
great.
just talking about the reconciliation thing because we had a liver donor, so she was on anti-epileptics and she was taking actually carbamazepine specifically. So we know like it's a liver donor procedure, so it's a liver toxic drug as well. So usually what we do is that we need to stop all these drugs pre-op, and also we make sure these medications are started only after 2 to 3 weeks once the patient is stable, once she has fully recovered and everything. So what happened is that the patient's medication reconciliation was missed, and we had actually continued the carbamazepine throughout the procedure, even the pre-op and also the post-op. Also, when she was in the ICU, she was continuously receiving carbamazepine. And then what happened is that maybe after shifting to ward, the next week she had a bit of, she was found to be a bit of drowsy, and then we checked her ammonia levels, it was high, her bilirubin was also kind of deranged, and we were like tensed about what to do. And then we actually found out that, okay, the patient is still on carbamazepine, and we were all like asking why wasn't it looked into. So that's just the recently encountered thing. So that's why I have this thing in my mind. So it's very
Yeah,
important to do the reconciliation because what most of the time is that in ICU patients, especially, we tend to miss it out because the situation is like the patient just comes in with a condition, and then we are just looking into the managing the patient in that situation. I mean, like we are not looking into, okay, fine, what are the things there, what are the medications, because we just manage, we just deal with what is in
yeah,
front of us there. So those things are to be looked into, and most of the time I see the interns or the students also, they're a bit hesitant on reconciling the old medications because you have to talk to the patient's bystanders, you need to ask them like most of the time is that they're not educated enough. So if you ask them, they'll be like, okay, I'm taking some medicine, but I don't know the name or I don't know the dose. So because of the same reason, they're all hesitant to look into the, to reconcile, and they just look it from the system and everything. So I think that's an important part. So that's why I just wanted to, reiterate to all the attendees here, because all the students will be hearing, I guess. So medication
Yes.
reconciliation is one thing that's the most, it's like a important thing, and you really need to do it
Yes.
properly in a right way.
And I think so, just not medication. I think so, two cases, like in case where, not just the medication, asking whether patient is an alcoholic or, has a
Yeah,
tobacco history. You can advise whether the patient is risk with delirium or alcohol withdrawal, or, you can suggest a nicotine patch soon. Otherwise, the
yeah,
agitation sets in and, we are wondering why it is happening. So it is this
yeah.
underlying cause,
That's
not
right,
just the
because
medications.
yeah, that's because in the
Yeah.
in the ICU, especially the ICU delirium is very much common, and you really need to know the source actually. Is it the ICU
Yes.
delirium, or is it some withdrawal? You have to make sure. Okay, so I think that's the questions. That's all the questions from the audience, and it was a wonderful session. And in interest of time, I think we'll have to wind up today's interesting discussion here. So thank you so
Thank you
much,
so
Dr.
much.
Abde, for sharing your presentation. It was a wonderful, and you presented it in very simple terms. I'm quite sure all the students have benefited from it. And to all the students here out there, this is just the beginning. We have more such sessions we have planned out. So this was just a crash course. Now you will have to look into it very deeply. So we'll be coming up with different topics. So stay tuned and do listen to the upcoming sessions as well. So thank you so much, Dr. Abde. Thank you, FCPI. Thank you to all the attendees who has joined today. Thank you. Have a good
Thank you
day.
so much. Thank you so much, everyone at CPI. Anita. Thank you so much.
Thank you.